systems here. Okay, well, how it all began. You know, in the 1790s during the Napoleonic Wars, Jean-Luc Leray, Napoleon's battlefield surgeon, developed these flying ambulances, is what they called them. They essentially were horse-drawn wooden boxes where they could slide some people on stretchers into the back and take them from the battlefield to the hospital as it was. Not much changed during the Civil War. Soldiers were put on flat wagons and horse-drawn and taken back to Army surgical hospitals where, if they survived their wound, they often died from mass infection. Because prior to these times, penicillin hadn't been developed yet, and so infection was a major cause of mortality in injured soldiers. World War I saw the Volunteer Ambulance Corps and the advent of the automobile. The Korean and Vietnam Wars, that's where we started to see MASH-type units or cracker boxes. Also, helicopters were incorporated to get people from the battlefield back to the hospital. And it wasn't until the 1900s, actually mid-1900s, that non-military ambulance services started popping up in the United States. They were operated by hospitals and fire departments, primarily in Iowa. They were operated by funeral homes. And there still are a couple ambulance services in Iowa that are owned and operated by funeral homes. The early ambulance industry, there were no requirements or standards for equipment. There were no requirements or standards for training or the design of an ambulance. So if I felt like I wanted to be an ambulance company, I could take my station wagon and pop a red light on the top of it and a magnetic sign on the door that said Jeff's Ambulance, and off I'd go. There was no requirement for me to even be in back with the patient. And that's where funeral homes became primary operators of ambulance services. They would place the patient in the back of the hearse, and if the patient was dead, they would take them to the hospital if they were alive, and then take them to the funeral home if they were dead. In 1966 was the publication of the White Papers, and the White Papers talked about death and disability on American highways. And the Department of Transportation, the DOT, was charged with developing EMS standards and an EMS system because essentially the White Paper, when published, indicated that people are dying on the highways because there's nobody trained to take care of them after a motor vehicle collision. It was in the 1970s where the founding of the National Registry of EMTs occurred. The National Registry of EMTs, not to be confused with the National Association of EMTs, was a body designed to look at certifying providers at different EMS levels. And many, if not most, I think all 48 states use the National Registry as a accrediting body to certify their providers within their state. It was the National Registry of EMTs that adopted the EMT oath and the EMT Code of Ethics as well. In 1973, the National Emergency Medical Services System Act, passed by Congress, flooded the rural areas of the United States with money to help develop EMS systems. And NHTSA, the National Highway Traffic Safety Association, was also instrumental in developing standards for EMS systems. NHTSA, a arm or a break-off of the Department of Transportation, we're familiar with them in publishing safety crash data and those sort of things. But when it comes to EMS systems, the National Highway Traffic Safety Agency, or NHTSA, is a very important organization, as they're responsible for developing the components of an EMS system, as well as multiple publications throughout the last couple decades that talked about where EMS is at this point in time and what needs to occur in order for it to survive. The different parts of the EMS system, according to NHTSA, one was regulation and policy, and that was the national government saying that, each state needs to establish laws, policies, regulations concerning EMS within their state. And our Bureau of Emergency Trauma Services, or BETS, a subdivision of the Iowa Department of Public Health, is responsible for doing that. NHTSA also talked about resource management, and that was a centralized coordination of emergency treatment and transport resources. And that's something that we struggle with. Resource management does every county need multiple transporting ambulance services? And there are some counties in Iowa that may have up to 8 different transport services. And is that really good resource management? And I think those are things that continue to be discussed at a national level. Human resources and training were an important piece of this as well, because there were no standards early in EMS, and now NHTSA and other groups have established training requirements for the different levels of EMS providers and minimum standards for certification. Transportation dealt with the safe and reliable transportation of the sick and injured, which led to the development of ambulance manufacturer criteria, so that if a company wanted to make ambulances, they had to meet certain criteria and safety factors when making those ambulances. Facilities were part of the EMS system. The EMS services can pick these patients up, but where are they going to transport them? And we're really looking at time-critical conditions now when it comes to transportation. Things like heart attacks, strokes, and major trauma all are time-critical and are either being transported to the closest facility or the closest appropriate facility, whether it be a facility that does balloon angioplasty and catheterization of heart attack patients, or whether it be a major trauma center. Communication was to establish a universal access number, 911, and they were to dispatch ambulances. They were to dispatch ambulances to the scene, ambulance to the hospital, and also communication is important, that we have redundant communication, more than one form of communication, so that we can not only talk with ambulances and hospitals, but all our other partners that respond with this, to include law enforcement, fire, emergency management. Public information and education was part of the system development for system standards, and that required us as EMS providers to educate the public about the role of EMS, how to access EMS, and how we as EMS providers could be active and participate in injury prevention programs, because some things we cannot fix. Only prevention can fix them. And those are, let's say, for example, trauma. We know that the vast majority of all life-threatening trauma, if not trauma that causes death, is preventable. And that prevention relies on our ability to develop injury prevention programs. So that was a big, important part of EMS system development. Medical direction, we have to have oversight, some medical director who is accountable for EMS people within their system. So as an EMS provider, we can practice EMS within our scope of practice, which we'll talk about later, as long as we are overseen or directed or guided by a medical director within our community. Trauma systems. Iowa developed its trauma system back in 2001, where we looked at ways that we could triage trauma patients, and based on our triage, determine the most appropriate facility for them to be transported to. We have in place the out-of-hospital trauma triage destination decision protocol that you'll become familiar with within this course. And then evaluation, establishing a program for evaluating and improving effectiveness, which some would call quality management, total quality management, quality assurance, quality improvement. And it's just based on a concept that we all know that when we go out and take care of patients, that we do it to the best of our ability, but we also know there's room for improvement. And by monitoring our care, we can identify opportunities that allow us to improve. So components of an EMS system include emergency medical dispatchers. Now, some counties have 911, E911, emergency medical dispatchers, or EMDs, I should say, is what they're called. And some got them and then didn't renew because of the cost associated with them. And there are some that have never been trained at that particular level. An emergency medical dispatcher has a set of cards in front of them. When they get a call from a caller, they can ask certain questions, which leads them through an algorithm within the cards, and they end up with a scripted message that they can give the caller. It also includes EMS responders at all levels, whether it be an EMR, an EMT, an advanced EMT, or a paramedic. And then it includes the emergency department and the hospital. And within the hospital, doctors, nurses, and other allied health personnel like lab and radiology and mid-levels. And then specialty centers, whether they be burn units or major trauma centers or major stroke centers, those sort of things. And that's what they're talking about here. It takes all of us in the system. We have an inclusive EMS system within the state of Iowa involving everyone from the emergency responder all the way to the rehab person once the patient is discharged from the hospital. So it's important to know what medical services are available within our community and how important it is that EMS personnel know the capabilities of your community medical facilities. Because as an example, we know that when we're talking about stroke patients and their need for a head CT, if we think they're having a stroke, and our local facility, their CT scanner is down and they're putting in a brand new one, well, it doesn't make sense if we have a stroke patient to take them to a facility that doesn't have a CT scanner. So knowing those capabilities is important. And, of course, the consequences of transporting a patient to a facility not equipped to handle the problem is a delay in getting the patient the care that they need, which the delay could be costly. So assessing the EMS system begins with the patient or the caller, because sometimes the patient doesn't make the call. The call goes into a comm center where an emergency medical dispatcher dispatches emergency medical responders, whether they be fire, first responders, EMTs, advanced EMTs, and paramedics, who then package and transport the patient to the emergency department, where in the emergency department they're cared for by not only doctors and nurses but other allied health staff. So gaining access to the EMS system requires a universal number, and of course we know ours is 911. Some of it is enhanced where they can triangulate where the call is coming from, so they'll know the location. Emergency medical dispatchers, as we mentioned, can provide instructions, and those instructions may be some life-saving information to get the caller to provide some care prior to the ambulance getting there. Critical decision making is a very important concept in EMS, and it's very difficult to learn. Critical thinking is something that you develop as you become more familiar with things like pattern recognition. You become more familiar with different disease processes and the stages of the disease and how that affects the body as you become more familiar with anatomy and physiology. So critical decision making is very difficult to teach. It's something that you learn based on experience. And we know that the decisions that you make as an EMT often can be very time critical. Whether we stay with the patient and provide care on scene, or we move quickly and transport the patient to a facility where they can receive further care. So some examples of critical decisions: is it better to take the patient to the closest hospital or to one further away, but has more appropriate is more appropriate for the condition? So let's say I'm in Le Mars, for example, and Le Mars is 28 miles from Sioux City, and I'm down there on Highway 75 between Le Mars and Merrill, and I'm working a major motor vehicle collision, and my patient has a serious life threat from their traumatic injury. Does it make sense to go back to Le Mars, or does it make sense to go another 20 miles in the opposite direction to a level 1 or level 2 trauma care facility? Is the patient stable enough for further evaluation on scene, or should the patient be transported immediately? We're going to have to make those decisions as to whether or not we believe we have time to stay with the patient and get a good history and good discussion and do the things that we're taught to do, or whether we just provide life-saving treatment like administer oxygen assist ventilations, cover holes in the chest, and then transport them immediately. And then we're going to learn to do different treatments and provide different care. And it's just important to know at what time do we provide the care, because we'll have patients that we're very, very busy with because of the seriousness of their injuries or their medical condition, and we may not get through everything that we think that we should because of the need to move the patient quickly to a hospital. There are different levels of EMS training that's out there for you. You got the emergency medical responder, and that was previously called the first responder. First responder is a term the federal government took over when after 9/11 to mean the first person who comes in contact with the patient, which could be the lay rescuer. So they're now called emergency medical responders. And then you're taking the emergency medical technician course, and they were previously called EMT basics. And then the advanced EMT was previously called the EMT intermediate, and then the paramedic was previously called the paramedic or paramedic specialist. Some roles and responsibilities that you have as an EMT, first and foremost, is your personal safety. You're going to find yourself in situations that are hostile, situations that are dangerous, and we all want everybody to go home at night, so it's just really important that you focus on scene safety. Then safety of the crew, safety of the patients, and lastly, safety of the bystanders. You're responsible for doing a patient assessment. 80% of the diagnosis, or 80% of figuring out what's wrong with your patient, you're going to acquire by doing a good patient assessment and obtaining a good history, and we'll talk about that. You will provide patient care, some on scene, some in the ambulance, and some in hospitals as well. It's going to require a lot of lifting and moving, so we will cover lifting and moving and the importance of doing that properly. You'll be transporting patients from the scene to the hospital, from hospital to hospital, from nursing home to hospital, those sort of things. And then once you deliver the patient to the receiving facility, you're going to have to transfer that care to somebody of equal or more training. And I think one of the important things that we should keep in mind about being an EMT is our role as a patient advocate. Many times the nurses and the doctors don't see the home. They don't see the scene. They're not familiar with the patient. So it's important for you to be an advocate to make sure that the patient information is transferred properly so that you paint a good picture of the situation that the patient's in. So how would it impact an older adult patient if they were transported to the hospital without glasses, hearing aids, or dentures? Those are things that they rely on to see and to hear and to eat. So obviously, if they couldn't see, if they couldn't hear well, if they had trouble eating, that could be problematic for the patient. So it's important that if you are caring for a patient and they're able to talk to you, especially if you notice they don't have their teeth in, or you notice they're having a hard time hearing you, asking them about, do they have hearing aids? Do they have teeth? Where are they? And then get those things for them. On our routine call, would taking the time to gather these items have a negative effect on the patient care? And the answer is no, not on a routine call. Again, there's only 3 real time critical situations that we deal with. One is a stroke, one is a heart attack, and the other is a life-threatening traumatic injury. So how about assuring the home is secure and locked before leaving? And that's one of the things that, you'll do as an EMT. It's just a courtesy. If the patient lives alone and you've got them strapped to a stretcher and you're taking them out the door, they may find it more comfortable if they know that you're going to lock the door and put their keys in their purse and that they hold on to their purse and, that sort of thing. Could the concept of patient advocacy also extend to the community? And the answer is yes. The number one cause of death in the elderly is falls. So a fall prevention program for the elderly is something that an EMS provider could spearhead within their community, as well as poisoning awareness, pool and water safety programs for children. All those things are patient advocate and prevention programs that as an EMT you could be involved in. Now, you can imagine that as an EMT, there certainly are some physical attributes or traits that you're going to need, and one of them is the ability to lift and carry patients up to 125 pounds. The cot itself weighs about 70 pounds anymore with the power cots and their battery and that sort of stuff. And then you've got the patient on there and you've got equipment on there. But collectively, if you and your partners, are able to each lift 125 pounds, you should be able to carry most patients. You need to have good eyesight for distance and reading because you're going to be looking at small labels and those sort of things. You should be aware whether or not you're colorblind, because that may affect your ability to interpret some of the stuff that you assess as an EMT. You need to have good communication skills, both oral and written skills, because you're going to have to give verbal reports about your patient's condition to the receiving facility, as well as write a patient care report. You need to be pleasant. I know that getting called out at 3 o'clock in the morning in the rain is just not a very pleasant thing to do or deal with, but that's what we sign up for. We don't pick our patients. We can't choose the conditions that we respond in. They chose us, and it's important that when we do respond, that we are pleasant, that we're sincere, that we are resourceful, because you'll learn to do things, but in reality, situations may dictate that, there's just not enough room to get a longboard in here to get the patient on. So how am I going to move the patient without a longboard? You need to be a self-starter, and I think that's one thing that's very common in all successful people in EMS, the ability to, to take the bull by the horns and problem solve. You need to be emotionally stable to start with. There are many people who are in EMS for any length of time do develop post-traumatic stress disorder, and that's because of the type of calls that we respond to. Some of them are horrific in nature, and some of them end a person's career before it really even gets started. You need to be able to lead, take control. You need to be neat, clean, have good moral character, and respectful of others. Now, we'll talk about ethics being a community belief system, and moral is, something that you own, that you believe in or belongs to you. So good moral character is important because there's no room for bias in EMS, and we all have biases, and it's very hard not to allow our biases to cloud some of the care that we provide. And we wouldn't think so, but all the research says that we do. You want to be in control of your personal habits. You want to be able to have control in conversation and be able to communicate properly. And just as, important as communicating properly, you're going to need to be able to listen to others as well. You're going to need to be a good listener so that you can understand what the patient is trying to tell you. And it's important that we approach patient care with empathy. We also approach patient care non-judgmental and fair, treating all patients as we would want our family members to be treated. We need to keep our skills up to date. Skill deterioration is common in EMS. Not that we have a lot of technical skills, but if they're high-risk, low-frequency skills that we don't perform very often, we really need to stay up to date on those. We need to take refresher courses when our certifications are due, when our CPR is due, when any of the other courses you take are due, like PHTLS or AMLS. You need to go to continuing education courses, conferences, seminars, lectures. As an EMT, you're going to be required to have a certain number of continuing education hours in order to renew your EMT when the time comes. So where will you become a provider? As an EMT, you could work for an ambulance service. You could work in a fire department. You could be fire/EMS. Rural and wilderness teams need EMTs. Urban and industrial settings need EMTs. And, of course, volunteering with your local search and rescue, fire rescue, those sort of organizations. Now, the National Registry of EMTs, they handle all the registration for EMRs, EMTs, advanced EMTs, and paramedics who successfully complete the National Registry exams. So at the end of your course, you're going to take both a written exam and a practical exam that has been validated, and should you pass, not should, you will, when you pass the exam, you'll get that certification. And by passing National Registry, again, 48 states acknowledge that as a competency and allows you to move from state to state without having to take their state tests or having to reapply for a state license. So it does help you with reciprocity, and it does help you when applying for employment. Now, quality improvement, here we're talking about continuous quality improvement, and it really works best if we approach continuous quality improvement with a self-review or a self-evaluation. You'll find out in EMS that everybody's a critic, and we are our worst critics, but we need to do a self-reflection of our care following each call to identify things that perhaps we could have done better. And by doing that, without beating ourselves up too much, we certainly can make changes and improve the way in which we provide care. Now, everyone in an organization has a role in continuous quality improvement, from the person preparing the written documentation to those who are actually involved in auditing the run reports, for those who obtain feedback from patients and hospital staff through evaluations. Quality improvement also includes maintaining your equipment, making sure that when you go out on a call and you need oxygen, the tank isn't empty, or when you need a specific piece of equipment, it's not all used up. Quality improvement also includes maintaining your education, completing your continuing education. All patient care is performed under the direction of a medical director, and we briefly talked about this already. The medical director has the ultimate responsibility for patient care because you're working under their license. Should you have a major error in the way that you provide care, that could affect the medical director's license as well. Medical directors are to oversee your training. They're to help develop your treatment protocols. They're to allow you with information to provide offline medical direction like standing orders or state protocols. And they're also available should you call them and need some online medical direction. Your role in public health is, certainly you're in the home of these patients, whether they be very young or very old, and you can, look at their environment. Knowing that falls is the number one cause of death in geriatric patients, if they've got a lot of loose rugs that they could easily trip or slip on, then letting public health know that, or letting some family member know that perhaps you could get some double-sided tape and tape those down. And then injury prevention programs for the youth, which include bicycle rodeos where you're issuing helmets and teaching them safe bicycle habits. And then participating in public vaccination programs, certainly keeping up your immunizations, and then disease surveillance. Should you notice an influx of the number of patients that you're picking up with the same symptoms over a week's period of time, could indicate the influenza is present. Research is very sparse in EMS. The whole purpose of research is to focus on improving patient outcomes through evidence-based techniques. We're really looking at something called evidence-based medicine. Not only in EMS, but all levels of healthcare are basing what they do on evidence that shows what they do improves outcomes. And when developing evidence-based medicine, the process is to first form a hypothesis. And hypothesis is a belief. There's no proof to it, but the hypothesis is, let's say, for example, cervical collars immobilize the spine. You would think that if you put a rigid collar around somebody's neck, that it immobilizes their neck. And then you review literature and look at the available evidence that would either prove or disprove your hypotheses, and you evaluate that evidence for its level of robustness. Things like a random chart review is not a very effective method of doing research, where if you have a set of training and protocols and stuff beforehand, and then you apply those, and then you go back and look at the outcomes that the patient had. That's a much better research practice. And then, if the evidence supports your hypotheses, you should adopt it. If it doesn't, then you should move on and look at a new one. Not all research is created equal. Some is animal research, some is human research, some is randomized trial, blind, double placebo, all kinds of different things that are out there as far as the method of how they do medical research. And so you need to rely on the scientific method that is going to produce the most accurate result for what you're looking at. Exacting and comprehensive studies are both difficult and very time-consuming. And the problem with time is, we don't spend a lot of time with the patient in the field. We have them for such a short period of time. It is difficult to determine if what we do really makes a difference on the back end when they're discharged from the hospital. We do know things like early CPR, early defibrillation, those sort of things do make a difference. And then once we evaluate the research and extract the data, we can develop an objective opinion. And we'll talk about objective and subjective information when we look at documentation. So we all have biases, and biases cloud the way in which we see things. So some methods of reducing bias is to do a prospective study. Prospective is to do it to do the study live. Retrospective is to go back and look at charts. Randomization reduces bias. If I randomize the sampling that I take, in other words, on even days, we're going to do this. On odd days, we're going to do that. Then I really don't have any control over what type of patient gets it, just on the day. Control groups, again, you can identify ahead of time in your study who the control group is and apply this hypothesis only to that group. And then look at other similarities in other groups from other studies to see if your research or your data comes to the same conclusion that they do. Some types of medical research could be done on case studies and patient care reports. They can be cohort with other organizations or other people. They can be case-controlled studies where you only look at certain things. They can be randomized controlled trials, which by far are the most robust type of research out there. They could be systematic review, and meta-analysis is another method of looking at data and analyzing it. So questions to ask when you're thinking about evaluating a study is, identify the biases and the flaws in the methodology right away. You see this, and a good example would be, let's say that I got this new drug and I want to do some research to prove that this new drug is the cat's meow. Well, obviously, if I make the drug and I'm doing the research, there's a bias there. And then what sort of methodology did I use? Again, remember, retrospective is the least robust method of getting data. Questions to ask before participating in a study is, what do I need to do in the study, and what sort of information do I need to know before starting the study? You want to give it a name. You want to know who the investigator or the primary contact for the study is. You want to look at what the question or the hypothesis is that they're trying to prove, and what sort of people were included in the study as well as those that were excluded. What sort of conditions were included in the study as well as those that were excluded. What data do I need to collect? We're good in EMS about collecting lots and lots of data, but then what we do with it once it's done is something that we struggle with. Whenever you conduct a study on live people, you've got to have their consent. So how are you going to obtain that consent before enrolling them in the study group? If treatment is going to be randomized, how are you going to randomize that treatment? Are you going to in some randomized controlled trials, they have an envelope in the back of the ambulance, and on a specific day, if this patient meets the criteria to be in the study group, then you could open the envelope and see how they're going to be treated. So that's randomized as well. And then what sort of samples will need to be collected, and what sort of potential benefits is the patient going to achieve as a result of your study results. The risk to the patient as well. Has the study been reviewed and approved by a board? Does your medical director approve of the study? Does your EMS agency approve of the study? All those things need to be included when conducting research. So that's sort of a brief look at